Okay, we'll go ahead and get started and let people filter in. So if you haven't had food yet, please go ahead and grab a plate and grab some pizza. Welcome to the first, I think, Wilderness Medicine Joint Emergency Medicine Interest Group session that we've had in 2016. So we're welcoming Dr. Ron Brown. He drove a whole hour and a half down from Snohomish County today, so we're pleased to have him here. On a side note, if you are in the WWAMI region, check your email and you can send questions to August, and he will ask those to Ron live during the session right at the conclusion. So we're happy to have some participation from other sites. So quick introduction for Ron. Ron's been an emergency room physician for about 20 years now, working primarily up in Everett, Washington at Providence Regional Medical Center. He did his training, medical school and training at Emory, and was doing a surgical residency before he switched to emergency medicine. He was a medical program director in Snohomish County from 2005 to 2012. He stepped down from that, but he's still medical control and director for 4 different fire departments or stations in Snohomish County. In 2005, he started the Snohomish County Helicopter Rescue Team, which is a unique combination of fire department, sheriff's office, and volunteer search and rescue. It's the only helicopter team in the nation, if not the world, that has ALS capabilities, a Hoist capable rescue system, and mountain trained technicians. So it's unique in that regard. So the plan tonight is Ron will take us through about an hour of describing the program and going through some videos and some case studies. He welcomes questions at any point, and please use your microphone so that we can catch you on camera and broadcast it to the region. Okay, without any further ado.
Okay, we're having a little technical difficulty, so I can't use the clicker, etc. I usually like to wander, so if I look uncomfortable, it's because I'm tethered to the lectern. So is this, besides wilderness medicine, is it emergency medicine or EMS? Emergency medicine, okay. And so like most people in emergency medicine, a lot of them in surgery, et cetera, you know, I'm kind of a motor butt, adrenaline junkie type person, so I will try and stay within the confines of the camera here, but anyway. So as Miles said, I was the medical program director, which in the state of Washington is the physician that is responsible for EMS in a particular county. We don't have a state EMS medical director, so we have our little fiefdoms, like little counties all over. And then the first year that I became medical program director, the previous physician had died in office. So I came in totally cherry and had no idea what I was doing for about 2 years. And in my first year, one of the trauma control nurse from Providence was out kind of talking about their trauma program, Providence, and went by either Everett Mountain Rescue, probably Everett Mountain Rescue. And anyway, she's been a friend of mine for a long time, and she came and told me, did you know that they've got paramedics on a search and rescue helicopter out flying around? And I'm like, no. And so who's their medical director? I don't think they have one. I'm like, so one of my first ballsy edicts was an email that was a cease and desist order for them. And then I had the lead flight medic, Matt Abers, and Brian Schleicher came and schmoozed me. And then my approach to this was I went to the search and rescue deputy, who is, in the state, search and rescue is mandated under law enforcement, unless specifically something else is set up. And I told them that they could only have this program if I was allowed to do everything that the flight medics did. So I did that for about 10 years, and now I'm getting to the point where I don't want to take call anymore, but I still play. All right, so as Miles kind of said, this is a unique beast. Usually you don't get law enforcement and EMS/fire and volunteer search and rescue working together as well as it does with this particular team. In Snohomish County, fire, search and rescue, and law enforcement, the sheriff's office, have a history of working together a little bit better than, like, for instance, in King County, or at least it used to be in King County. But to put together one team like this was pretty unique. When it started out, it was a lot more kind of off the cuff. For instance, we evolved through many different procedures. We never got to rappel while I was on the team, but we did short hauls, which you'll see a little bit of. We didn't have a hoist. We used to just go and buy our own harnesses until, as the sheriff office became more aware of this, they're like, oh, don't go buy your own harnesses because, someone will buckle will give and someone will fall out, 800 feet down or something like that. So it was kind of been a unique 10 years as this has developed into a very professional team, especially for one that is mostly all volunteers. So we've got search and rescue for the expertise in manpower. So their expertise, for instance, with mountain rescue, which is, you'll see, is kind of a key part of this helicopter rescue team. And then manpower itself. Sometimes we need extra mountain rescue people. We'll talk about that too. Fire gives us manpower. Specifically, fire gives us our ALS components, or our paramedics. They have to be firefighter paramedics within Snohomish County full-time in order to volunteer on this service. And then fire also outside HRT does transport, and then they also supply us with medical equipment and the drugs. So one of the agencies that I'm the medical director for still is up in Gold Bar on the way to Stevens Pass, District 26, and they are our ALS partner for the HRT. And then, of course, the Sheriff's Office supplies command, statutory command, and coordination over all the different agencies. So currently we are at about 30 people. This is clearly not all of them, but we have 5 deputies, and it may be even down to 3 now, I think. These are the only people that are paid to be on the team. Everybody else is a volunteer. So the guys in green in the back are the air crews. So that's the crew chiefs and the pilots. And the guys in orange, the prison orange, state prison orange, are the rescue techs. And when we first started, they came from mountain rescue, but they had varying skill levels and had been on this helicopter rescue team has been around as kind of a just extraction type of an entity since 1970 something. And then the guys in blue are the paramedics. So we currently have 8 plus me. And then the ones in vests are our ground support unit, which is kind of an important thing for fuel and things like that. So we always fly with a crew of 5. Always 2 pilots, and that's rather unique. Airlift Northwest, only 1 pilot. Most of the air ambulances in the country only have 1 pilot. So if the pilot becomes inoperable for whatever reason, that could have devastating consequences. And it's not like you are in an airplane that glides. If this is not controlled, it becomes a giant sperm that just falls out of the sky. We've got a crew chief, so that's this guy. He directs the pilot with respect to the ground. They have a hard time knowing what's going on in the ground because they have to fix on a certain point on the horizon to kind of maintain whatever altitude and position that the crew chief tells them. We've got the flight medic in the blue and then the rescue tech. So these are called the left seat and the right seat. Sometimes they'll have to fly with 2 flight medics in certain situations. And sometimes we have to fly with just with 2 of the techs. So I'll get into their particular skill sets in a little bit. So it started out as a pilot program in 2004, so that's before I was medical program director, even knew what was going on. And then it kind of matured. We got our first cases in 2005. As I said, initially the rescue techs were just mountain rescue first aid, not in the EMS system. And there's a lot of statutory stuff involved with that, but we have a good indemnity law for liability for EMS in this state, a very good one. So, number one. Number two, as you mature in your clinical life and become clinicians, you have to try to put yourself in the position, way to be on time there. You'll find you're surrounded by other healthcare providers. You've got nurses, you've got techs, you've got other docs. When you're, baby doctors, you've got residents above you, et cetera. To take someone out of that and put them as the only clinical provider in a situation, particularly like on a mountainside, is kind of a scary thing. So several years ago, I mandated that the flight or the rescue techs needed to be either first responders, which is an EMT level, or EMT basics, and currently we're kind of getting everyone to the EMT basic level. We have minimum training requirements established, so they have to do Search and Rescue Academy, which kind of gears you towards self-sufficiency in the backcountry. Helicopter advanced courses. We have to do a fitness test every year to make sure that we can schlup the stuff around that we need to, and then navigation, map reading skills, etc. So the hard thing is to get people that have the proper mix of medical and technical training. So our rescue techs have advanced skills that are actually required for them. They have to be basically hot shit mountaineers. I mean, that's who I want in the right seat, because I am like the only person that's really thinking about a bad hurt patient. I don't want to have to think about the fact that I'm a little bit scared of heights and I'm on this mountainside and there's a bad runoff with what we call a bad exposure, which means it drops off into death or something like that. So that guy or that woman is the one that ties me into the mountain, and I don't even go down there unless I am sure that it's safe to do so. And we're such a tight-knit team now that they wouldn't let me come down if they didn't think that it was safe for me to do so. I'd like my paramedics to have some climbing experience. I've got some climbing experience. I will always be a novice climber, but I can do glacier travel. I can do some climbing. I know some ropes, and I've taken some rescue rigging classes through Search and Rescue. Problem is, you get paramedics or firefighters, now they're on the HRT, so they think they're really hot shit, and a lot of them are like, well, I'm good enough to do, I did ropes and, high angle stuff in the fire department. I'm like, not the same thing. But anyway, that's an ongoing evolution. So, and sometime in 2005, early 2005, we had our first case. This is our helicopter up at the top. It's I believe it was built in '76. And it's now a Super Huey. It's still only a single engine. However, it's got we got a Homeland Security grant not long after, about 3 years after 9/11, to get an upgraded engine and transmission. I remember one of my first missions, we flew to 6,600 feet north of Glacier Peak, and it's summertime. In the summertime, the air is hot, and it's not very dense, so there's not a lot for the blades to grab onto. So we had to come in like this and go out like that. We couldn't even go straight up, and only at 6,600 feet. So bigger engine, bigger transmission meant bigger blades, and now we can go a lot higher, particularly in the winter. We could go up to 10,000 feet. It all depends on how much weight you're carrying. We also have another helicopter in Snohomish County, which we call our Little Bird, and it's an ex-CIA helicopter, which is weirdly quiet. I don't get to ride on that, but it's got all kinds of cool stuff on it, like infrared cameras and tracking stuff, and it's totally packed with electronics. It's quite cool. All I get to do is look at it. So this is our base. There's I-5 and Everett there. So this is a little bit south of the middle of Snohomish County, where basically we're State Route 9 that runs all the way down here, and Highway 2 meet. It's called Taylor's Landing. So, and that's our county. That was kind of our initial area of response, but we quickly found, as the program got off the ground over the first 2 or 3 years, we started getting more and more calls, particularly from Chelan County, which is quite close to us, just over the crest, and so we get called by them a lot, to the point where they want their own HRT, and they've got plans to set it up, and I just said good luck with that money. But we've gone all the way to Kitsap County, Pierce County. We've even flown down to Rainier, although federal regulations make that kind of problematic. We do about 80 missions a year. Clearly, Search and Rescue does a lot more missions than that just in Snohomish County. But in order for us to send the helicopter in, which costs about $1,200 an hour to fly, that's not volunteer time, people having to leave work or whatever, that's just for the maintenance and the fuel. And to engage in air operations, particularly with volunteers, not just the deputies, it has to be cleared by command. And we can't do hoist stops unless our lieutenant clears it. It used to be the captain, now it's the lieutenant that clears it. So it ends up being about 80 missions a year. So we try to make sure the patient actually needs that level of risk on our part in order to go get them. So once we got our hoist in what year, do you remember? Maybe 2007? About 2007. It wasn't 5, about 7. Anyway, we really were able to ramp up because with this hoist, we can actually insert people. We used to have to do what's called a short haul. I'll show you a quick clip on it later, but there's a hook on the bottom of that aircraft just behind the word sheriff. It's a big hook, and we had this rope that's about long, 180 feet, something like that. It's about that thick. And they would go in, we would have to be inserted, basically. We'd have to climb off the helicopter, so we'd have to at least do a low hover where we get within a few feet of the ground. So that would mean a lot of times we would have to really hike up to a patient, which is crappy when you're carrying medical equipment. You have a heavy vest on and a heavy flight helmet, and you're sweating, etc. And then they would come back with that long rope dangling, and it was just a much less agile of a response. The only good part was when the patient lifted up, I could be hooked to the rope with that patient, and I could bag them. We never had to do that, but I mean, I could do surgery underneath. It's very peaceful and quiet underneath the helicopter. So, but the hoist ops, we were able to go into difficult areas to get to, and we'll see some of those cases today, and actually they hoist us down, insert us, usually meaning the rescue techs, to get the patient, do whatever they need to do. Sometimes we'll go down, whatever, package them up, and then get them out. And we have various ways of getting a patient out. So our hoist operations basically are 3 ways of getting a patient out. One is a litter. Another is something that's aptly named a screamer suit, although we don't tell them that. It looks like a ladybug kind of shell encasing you, or a big diaper. But it does make you feel like you're going to die. But it's still safer than the rescue strop. Rescue strop just is a strop that goes around, and you're supposed to have the patient hold on to that. And of course, we're hooked to it also, or we meaning the rescue tech is hooked to it also. But and we do have, which we'll see, a strap that goes underneath the patient's crotch, which is key because it was 3 years ago that in New Zealand, a deputy was taking out a patient with a strop with no crotch strap, and the patient was being compressed because when the strop goes up, it compresses the thorax, right? And that's going to limit a lot of things: venous return, the ability to breathe well. This was a middle-aged patient who then passed out and slipped right through, died. And so that deputy is now, in therapy for the rest of his life. Short haul is that hook underneath the helicopter. We still have that capability. We have a fancier capability. And then low hover is kind of the easiest, lowest risk, where the helicopter can actually get on a slope or to where they can't quite land, but they can get the one skid down close enough to the ground where we can actually climb out. And of course, that's the least risk. So the primary goal of the HRT is extracting the patient. It's fancy. We've got a paramedic. I've got the ability to intubate patients, to put them on a ventilator, do all kinds of stuff. But we would rather do that stuff in a more controlled atmosphere if we can. And it doesn't do any good if you're futzing around on a mountainside, going to intubate a patient, something like that, and they end up dying because you just didn't extract them and try to get them out. So scoop and run is still the basic tenet of what any good helicopter rescue team does. So this is an actual mission picture. I'm guessing that's you, Richard, maybe, or Brent Allen, one of the two. And so you can see we've got the prison orange rescue tech, and then we've got bystanders helping. We can only insert 2 people unless we do multiple and configure well and don't have weight, or do multiple insertions. So a lot of times using the bystanders is kind of a key thing, especially if you have to move a patient. So extraction first. This is a litter extraction. That is what we call the Bauman bag. That we have this nice old lady somewhere in Snohomish County that makes these for us, and it's got a harness hooked to it. So the way it goes is the rescue tech goes down, the medic goes down, the rescue bag goes down with all our stuff in it. Patient gets treated, evaluated, treated, and packaged. And then the medic's going to go up first, followed by the patient, and last the rescue tech's going to go up because we want someone medical up there to meet the patient and besides just pulling him inside, and the crew chief can't really do that well. So what we'll do is we'll extract that patient, and then the best of all worlds is to then go to a flat spot where we can, if we've got time, turn off the helicopter, let it spin down, and then get out and do stuff. So this is actually one of my rescue techs who is, again, he's a hot shit mountaineer. Right? He's a president of Everett Mountain Rescue, or at least he was. And then there's me, a doctor, right? And so it's like, how long it has been since I put an IV in? You know, the nurses in the emergency room always run up to me and say, we can't get an IV in, you know, such and such. Can you? I'm like, I don't do IVs anymore. So I did tons when I was a medical student and a resident. Luckily, however, the blonde who is the co-pilot is also a Snohomish County paramedic. So I said, here, put a line in. Here, give him some morphine. I don't know how to mix up this stuff, so you go ahead and do it. And it worked out great. So what I did is I taught the rescue tech how to roll gauze on a wound. So it was great. This guy, he's in a litter now, which I wanted him to be in, but we couldn't extract him in that litter. He was a fall. I don't think we cover him in this lecture, but he was a fall, a guy that was up at about 9,000 feet on Mount Goody up in Snohomish County. It was getting in the evening. He threw an anchor around a rock, and if any of you climb, you know that a lot of our rock is crap. It breaks really easily. So, and he was relatively novice. So instead of easing back and putting gentle increased pressure on his anchor, he shock loaded it by just kind of dropping back, and it broke. A piece of the boulder came off, smacked him in the head. He had a helmet on. Ended up breaking his C-spine around C1 or C2, I don't remember which. Clearly it was a stable fracture. He spent the night crouched like this for 12 hours waiting for us to come and get him. But shattered elbow, open fracture, dislocation of the elbow, and a bunch of lacerations, etc. So on his rescue, we flew out there. He's crouched in this little area about this big. There's a couple climbing rangers from Mount Baker Snoqualmie National Forest. His climbing partner, the girl I think he was trying to impress, and no room for a litter or anything like that. They landed the rescue tech, so they're on here. There's a big talus field that comes down around 200 feet and then drops off for a few thousand feet, and then a rocky buttress where we landed the rescue tech. And I watched him work his way without a rope just over this talus field, and was just about to tell the pilot, there's no way in hell I'm going down there, when they said, yeah, we're not going to send the doc down there. So he went, and very little experience, but he knew enough from his EMT training to go up to the guy, take a look at him, he's conscious alert, breathing okay, and then we were going to screamer suit him out, which we did. He pressed down on his head and says, does that hurt your neck? Yeah, it does. So put a C-collar on him, brought him up. The guy's pulse was 72. I expected him to be all pale and diaphoretic and ready to vomit and stuff, but he looked great. So I sat him in the seat, brought up a rescue tech, then flew out and laid him down, you know, a little bit more spine immobilization, et cetera, on the scene there. So what's the need for a helicopter rescue team? The main thing is extraction and of more hurt patients, so sicker patients. Primarily, it's trauma. We see, as you would guess, a significant percentage are orthopedic injuries. We're not talking about twisted ankles. We don't fly those out. An ankle fracture dislocation that's open or something, those will fly out. And it's for the HRT, so for search and rescue as a whole, the majority of what you do are either lost, maybe a little dehydrated or exposed, whatever, and then an orthopedic injury. For us on HRT, we tend to have more multi-system trauma. So a significant fall, more than one injury. It's not just orthopedic stuff, et cetera. But we have had medical stuff. So one of the early patients that we got had chest pain after he climbed up 4,000, 3,000 feet or so onto a ridge, flew out there, got him. He looked okay, gave him an aspirin, flew him to Providence. Still early in the program, so Providence was having a fire drill, so we couldn't get off the helipad for a little bit. Brought him down, chest pain patient, hooked him up to a 12 lead. He's having a STEMI. So we do have the capability to do a 12 lead. Sometimes you just don't think about it. It's not going to change what you do. Anyway, that was a learning case. Dehydration is common, but doesn't generally require a hoist. But we have had dehydration that was so bad the person had a pulse in the 140, 150 range and was unable to break camp and self-extricate. Once you get to a certain point of dehydration, oral rehydration is problematic and may not work. This one case was an older guy who was a ham radio enthusiast, and he managed to get a signal out by Morse code on his radio to a guy in Montana with his location, and we went and picked him up, and that was from diarrhea. So infectious disease is something else. That's generally going to be acute gastroenteritis. It's going to take people out. And then we've had other ones. I've taken a patient with a kidney stone out, which you may say, a kidney stone, that's no big deal. If you've not had a kidney stone, you would say that. And he was a 2-day, that was the one I told you about where we had to come in at a shallow angle and leave at a shallow angle. He was a 2-day hike out, and he's like, well, it's not hurting me right now, so I feel a little silly. I'm like, in 4 hours, you're not going to feel silly. So, we've got all kinds of patients that we bring out. Some mitigating factors. So the golden hour is of limited importance. You guys know what the golden hour is? The surgical concept of, in multi-system trauma and bad trauma, you've got basically an hour to get hemorrhage under control, okay, and save a patient. If you don't act within that hour, the mortality goes way up in a significantly injured patient. That's where the whole concept of ATLS came from, which you won't do probably till the end of medical school or beginning of residency, especially if you're going to be a surgeon or something. But that's where that comes from. Clearly, that doesn't apply to us. Even though the cell phone towers, Verizon in particular, are great, and a lot more people have spots in reach, different satellite beacon communicators, or just a pure PLB, personal locator beacon, it still takes time. We got a 20-minute, 30-minute response time to Taylor's Landing. If I was to go there today, we would have to do a dry run to make sure everybody's on the same page and everybody's up to skill and snuff, et cetera. A basic tenet for any of you that were an EMT or a paramedic of rescue is what? Scene safety, which revolves around rescuer safety, so you don't create more victims. So it's going to be a while before we get out there. The fastest response time we ever had was OSO, and that was because they were spinning up for a training flight. It was literally turning the helicopter on and spinning the blades when the call came out. So the reds generally die. That becomes a recovery. It's not that often that we're going to have someone who is truly a red at the time of their injury that's going to last for 4 hours or even 12 hours, et cetera. So what we see are oranges and yellows kind of turning more acute as things like continued hemorrhage, dehydration, hypothermia, which hypothermia plus multi-system trauma is a bad equation, as those things start to take effect. And we've actually had cases of head injury with cerebral edema that took hours for basically them to get the call out, et cetera, and ended up the person herniated just about the time that they were going to be hoisted up into the helicopter, and then they started CPR, and that didn't turn out well. So hypothermia and dehydration are expected complications for us to deal with, so we always try to warm and rehydrate a patient. But by and large, extraction remains primary intervention. Even if they turn into a red, they're really hurt, if the best thing for them is we pick them up and then we fly straight to the hospital, and you can't do a lot of stuff inside that Huey, even though it looks big. It's really hard to hear anything. You can't check for lung sounds. You try to feel for a pulse. You can put them on a monitor. But even, you can probably put an IV in, but advanced airway stuff, you're not going to be able to do very well, et cetera. So you've got to kind of weigh that stuff. Another mitigating factor is prolonged time in the field. When we go out on a mission or even a training flight, each of us has to take a personal pack with 3 days worth of goodies. So if we get left, and usually that's the rescue tech getting left, they have to be able to take care of themselves and or self-extricate by foot, okay? And sometimes weather closes in. So we've gone out, inserted. If you've been up in the Cascades, it can close in a matter of minutes. Helicopter will leave. Otherwise, it's grounded for who knows how long. The pilots are not nearly as prepared to be outdoors as we are. So, we had a case that Mountain Rescue got to in Three Fingers in about the center of Snohomish County several years ago, where they were with the patient for 36 hours, waiting for the weather to break enough to get him out because the trail was so bad that ground extraction wouldn't work. He had a tibial plateau, a tib-fib fracture, so clearly he was not going to be mobile at all, and the chance of injuring the ground pounders, as we call them, was too great. So he was well hydrated and he was nice and warm by the time he got out, but he was in a lot of pain. An increased risk to rescuers. So that's terrain, obviously, in the mountains, the weather conditions that we talked about, the mere fact that we're doing air operations and helicopters should not be in the air, just physics, that just shouldn't be. That adds to increased risk to the rescuers alone. So a few case studies. This is a totally posed picture, by the way. Can you tell? All right, case number 1. We had a leg injury up on Vesper Peak in September of 2010. This young lady has posted on the web, at least I think it's still on the web, a whole bunch of this stuff. I took most of this stuff directly from her posting. So the call came out as an open leg fracture. One of the most difficult things is for the deputy, the SAR deputy, who's the person on call for that day for search and rescue, to decide what kind of response to do, because reporting party specifics can be so vague or wrong or whatever, and it's being reported to a deputy, not a medical person. So, trying to decide what to do. But it was communicated well enough. It was an open leg fracture, and she was stuck on the side of a mountain. So a female climber with a fall, arrested by ropes, sustained a lower extremity injury, probable fracture, and bleeding. So that's all we knew. So they called out Snohomish 10 for that. This is where it was from her webpage. So it's at Vesper Peak down here, which is a peak I've climbed. You kind of come up this way along the red lines, and then the sane people just go up like this because you can walk up that way. And the insane people, which are climbers, go around into the really steep side and then go straight up. And that's what she did, and then ended up getting injured there. So, see that arrow up at the top that says descend east flank? Well, that's the way I go up that peak, because it's a long enough hike as it is. And you can see how we've got just basically, a gully, but it's straight up and down. But that's what climbers like to do. And I like the ledge bypass. I don't know if you could read that, but if it looks too kind of hairy down there, you just, I don't know, hand over hand crawl across the cliff face to get to that side and then go up. So this is what she and her climbing partner were doing, and they're quite experienced. And this is from her own journal online. So she said, suddenly a rock flake I was standing on broke loose. I felt my left foot rotate inwards, either as my foot was caught between some rocks with the body torquing, or was torqued out by the rock fall itself. And she remembers thinking, my foot is hurt bad, this is not good. She fell cleanly into the air, not getting tangled, 15 feet, rope caught on her top anchor, which didn't give way, so that's good. And then she looked down and she could see her foot in the boot flopping around unnaturally. She now had another joint. And I like this. She said, my splintered tibia poking out of my lower leg, blood and yellowish white fluid was flowing but not spurting. For a civilian, that's pretty descriptive, right? So we've got fatty tissue and bleeding, which is non-arterial. She's still hurt bad, and she's now hanging on a rope on a cliff face, but at least she's alive. I wonder if I can make it down alone. That's a climber, right? Looking at your foot flopping around, the bone sticking out, thinking, can I self-rescue, right? So always give a climber 24 hours to self-rescue. I asked myself, probably not. More mature decision making. I watched the blood already dripping through the jacket that was tied around my badly broken leg. I pondered the rugged rock walls surrounding me. This could be worse, I thought. I was fortunate I did not hit my head or break my back. The rope caught my fall, but it also could be better. So pretty succinctly and maturely put there. This is a picture she took while she's waiting for rescue. So her leg is coming from the lower left. You can see some skin here. You can see some blood on the blanket or whatever she tied around it. She's still got her boot on. Really intelligently, she took her ice axe and made a great splint. So the pick and blade part of it she used for the foot, and then the ice axe up the lower leg, and then wrapped that as best she could using webbing with a carabiner to hold it in place. And then she tied that to a tree to keep it elevated so she didn't have to elevate it herself. How big was the ledge she was on? Like 2 by 3 or something? It was basically a seat or maybe a bench. A bench for two people, possibly. Were you able to stand on it? This is a gentleman that went and rescued her. Actually, I didn't stand there. He went downstairs the stairs. Okay. So this is her picture of approximately where she was. A little close up. It's kind of blurry, but you can see it's still pretty dang steep now. So it's about this big of an area, a little ledge that she managed to sit herself on and wait for rescue. And then, of course, there's the boredom. She brought alphabet crackers, so she was just taking pictures and writing little messages to the world. By the way, for you people out in the other states, that says crap. So the extraction, so we sent, the rescue tech went down, just enough room, I guess, for him to stand. He got her untied from the tree and then put a screamer suit on her, which we'll see in a second. Noted some active hemorrhage. Clearly it wasn't terrible, otherwise she would have been dead by now. Brought her up, and then they landed close by at Copper Lake, where the flight medic was able to do more than just a primary exam, more thorough secondary exam, I should say, and then beginning addressing the wounds and the fracture. So there's a sterile bandage, a splint, antibiotics were given. We had just started some advanced protocol and some pain medication, and then transported to the hospital at Providence. So that's our new tower there with their, it can't hold the Black Hawk helicopters the military uses, but it holds the Huey just fine. So what happened to her? She had a distal tibia and fibula fracture, so she had an open reduction internal fixation done. She had to have a saphenous vein graft because the vein, that's the big vein in your lower leg there, because it was so badly damaged, and then she actually developed compartment syndrome. So she had to have a fasciotomy. So there's her ORIF. You can see all the staples there, and then the big plate, and you can actually see the fracture here, right? We've got multiple pieces, so there's a distal fracture through that, a fracture higher, which is why this plate there is so long, and we don't have a good view of the tibia, or the fibula, but we don't really need that. That's what her leg looked like in the hospital. Not very attractive, but you can see the fasciotomy, which was done laterally, and then that's a skin graft. That kind of waffle pattern there is the evidence of a skin graft, which was probably taken from her thigh. What were the challenges on that particular case? The terrain, clearly. It was straight up and down with a small little bench for the rescue tech. No room for the flight medic, no room to set up a litter, all right? You know, and with a distracting injury like that, you can't adequately evaluate for spinal injury or anything. So, but what's the basic tenet of this type of rescue? Extraction. Doesn't do any good if you sit there and worry about spine immobilization and were to try to set up some weird hanging litter type thing to get her into if it ends up she's out there longer, gets more exposed, or something happens and she dies. So that was difficult and dangerous for both the patient and the rescuers, and we couldn't do standard spine immobilization prior to the extraction. And then the wounds were the other challenge. So she had an open fracture, and she'd already been in the field for hours. So clearly this is going to be cleaned out in the OR. This is an indication, an open fracture is an indication, unless it's a finger, for orthopedics to take the patient into the OR and really irrigate the hell out of that wound so that they don't develop osteomyelitis, bone infection. So that she was out there for a long time. So flight medic did some cleansing and irrigation of the wound, copious irrigation of the wound, and then administered antibiotics to try to stave off that. So this is our first video. We don't have any audio on this one anyway, but I think we've got audio on the other one. So this is a GoPro on the rescue tech's head if it makes you kind of nauseated. But that's the flight medic being taken up there. So you can see how it is. It's kind of a recumbent type position. Clearly not great for the spine, but if they don't already have a deficit, then they probably won't get one. But if they do, they couldn't stay on the mountainside anyway, and there's no other way to get them off. So this is an actual screamer suit patient being taken up. You can't see him very well there, but here you can see him. He's got little climbing shoes on, and then his left leg is bandaged there. And then you can see this thing called a tag line going off diagonally to the left there. That's to keep them from spinning around. It's a normal thing when you're hoisting. Cables are spun that they want to spin when they go up, and that can really make you vertiginous and nauseated and vomit, etc. And that could be especially bad if you're trapped in a litter and unable to roll, turn your head or something like that, of course you could vomit and aspirate. So their tagline helps prevent that. All right, next case. This is a fall from Mount Pilchuck. This is a multiple trauma in September of 2012. Mount Pilchuck is a very popular hiking destination in Snohomish County, not very far out of town at Granite Falls. Call came out as a pediatric fall from Pilchuck fire lookout with a head injury. 14-year-old Boy Scout is what it turned out to be. The water bottle, they were up at the top. It started to roll and bounce, and he went after it. And then he went right over the cliff. And he went down about 100 feet. Luckily, there were a lot of people up there, and one of them was a cardiothoracic surgeon from Providence who got down, they down climbed to the patient, several of them did, and were with the patient, kind of providing spinal motion restriction down at the bottom there. But he ended up in a gully in a not very advantageous position, but they didn't want to move him because of the possibility of spinal injury, and he was obviously head injured. He was actually head down about 30 degrees, which is 60 degrees opposite of what you want a head injury. You want 30 degrees up, not down, right? Because what's the worst thing that happens with a head injury? Cerebral edema, swelling, herniation, bad news all the way around. And then it was debris filled with a lot of sharp stones, etc. So moving him was problematic. So that's looking towards the west from the east. You can actually see the Olympics in the distance there. And that's the north face. So it's quite steep. The other side is not as bad. And the trail comes up from the other side of that lookout, or the main trail does. So you can see the top of the lookout there and the approximate area of the rescue. So it's a good ways down. It's a lot steeper than it looks in this picture. The physician bystander provided cervical spine control. The patient was lifted once we got there, lifted with more than one bystander, right? Yeah. And the litter was slid underneath this patient, and then he was secured to the litter, and then brought, as I recall, he was brought down, set down, a secondary examination prior to hoisting. Is that correct? Yeah. So, and these are actual pictures from other people on the scene, other hikers there, of the litter extraction. So you can see barely the tagline coming off to the right there to keep the kid from spinning around so much. As the crew chief, who is on the edge of the deck there, is waiting to receive the patient, flight medic is already up in the helicopter. Is going to pull him inside, and then we'll zip up the flight medic. Secondary examination showed him to be hypotensive and tachycardic. That's also bad with a head injury, clearly, because if your blood pressure drops below or too near the intracranial pressure, you can stop perfusing. So hypertension and hypotension are bad for head injuries. C-collar was placed. He was in the litter for spine immobilization. Got a just over 20 milliliter per kilogram bolus of normal saline to kind of rehydrate and bring up his pressure, and then basic wound care, and then flown to Providence, Everett. So he ended up having a head injury. He had blunt trauma to the thorax. He had a pelvic fracture. I'll show you pictures of an L1 burst fracture, which is, burst fractures are bad. That's the weight-bearing body of the vertebra bursts, right? So it's unstable and high risk of a spinal cord injury. He ruptured his bladder with the pelvic fracture, had a traumatic brain injury. Scapular fractures are bad too because they imply, it takes a lot of force to break a scapula, a lot, okay? Ended up being stabilized at Providence and then transferred down to Harborview because he needed a PICU, basically. Have you guys ever seen a picture of a pelvis on x-ray? You see there's a couple bad things. So one of the things is this shouldn't be this wide, right? It should be about that wide. So the ligament is completely disrupted there. Right under there is the bladder. This is fractured too, but that's not as bad. There are bony rings in your body, and generally when one part of a ring breaks, another part of the ring has to break. Okay, it's very seldom that you get one break in a ring. It's usually a little old lady that it happens to because her bones are kind of like styrofoam. All right, so you always have to look elsewhere. So if you look up at the SI, the sacroiliac joint, you can see it's kind of widened there also. That's bad because that area you can get a lot of bleeding, arteriolar bleeding, venual bleeding, capillary bleeding. It's really hard to stop, and the interventional radiology has to go in and embolize that to stop the bleeding. This is another ring. This is one that commonly fractures, but this is totally stable. So this piece is broken off and free there, but it's not a big deal. So that's a bad fracture. So the challenges on this case were manpower, and the good thing is it's popular trail, so there are a lot of bystanders, but that can be plus or minus. Some bystanders can be helpful, and sometimes they can get in the way. And it can be particularly bad if we have to do a helicopter landing with bystanders around, because they don't understand the fact that the tail rotor is completely silent, doesn't have a motor of its own, and can kill someone, get in the way of the ground operations, that type of stuff. But by and large, we'd like to have some bystanders because they can help us carry. It's really hard for two people to carry, especially in more challenging terrain. This terrain was difficult, not as difficult as the previous one, but it made the primary exam difficult. He was head down. It was a kind of an unstable little slope there. So, but we could move him not too far and then check him out with a secondary exam. So the resources we had were one flight medic, one rescue tech, and then we had bystanders, and one of which was a physician who also didn't get in the way. Because sometimes doctors can be a total pain in the ass up there, especially if they say, I'm a doctor, and they turn out to be a PhD in history or something like that, or a podiatrist or something. So, because it always impresses the deputies. It's hard to, well, there's a doctor. Well, one of the first cases we brought down off Pilchuck was a guy who had fallen down one of the avalanche chutes, and so he was seen by a doctor up there, and who said he could hike out. So Snohomish 10 just landed at this big parking area at 3,200 feet on Mount Pilchuck. Flight medic, which is Matt Abers, I think it was his first case, he starts walking up the trail and meets this guy who's 45 years old, thought he was 20 years old from his head injury, and had impaled himself on his ice axe into his torso, which was missed by whatever kind of doctor this was. So don't be all eager to say, I'm a doctor, unless you actually know what you're doing. It's like, I'd rather have an EMT or a paramedic, somebody in emergency medicine, or a surgeon. So this is a surgeon, and he didn't get in our way, which was nice. And I think this, yeah. Well, again, the flight medic is already up in the helicopter, and so this is just the patient and the rescue tech. That's the tagline he's going to manage. And generally, the helicopter will slide away from the slope to provide an angle for the tagline so that there's less spin. If it comes straight down, it won't prevent the spin at all. We'll actually see in another one. One more case. How am I doing for time? Granite Mountain climbing injury in January of 2013. Here we had two males. The main patient was 40 years old. He was with his climbing partner. I can't remember if they were roped together or not. I don't think they were. They were crossing an avalanche chute high up, and the patient slipped, must have hit his partner. They both went tumbling down, and then so it was a 45 degree slope, which is really steep, especially with an icy avalanche chute. Came to rest down at the bottom where it's only 15 degrees, so it wasn't, the terrain wasn't as sketchy for the rescuers, except the fact that you're at the bottom of an avalanche chute, and that's always a possibility of having more stuff fall on you. You can see the rocks up all the way up the avalanche chute, and blood splattered on the stone as the guy tumbled down. Our initial call was for two probable patients with a head injury in at least one of them, which is problematic. We're only sending out two people. What do we do if we have two patients? We have to triage, we have to figure out what to do, and there were no bystanders. Primary patient, he didn't have a loss of consciousness. He complained of a loss of feeling in his legs earlier, and then it got better, and he had chest pain with increasing respiratory distress. So, number one, he had a neurologic finding, lower extremity. That speaks of a spine injury. And then he's got some kind of increasing respiratory distress. He's have a pneumothorax, a hemothorax. What's going on? So he's still sick. He's got neck pain also, and he's got bilateral ankle pain. On exam, he's found to have cervical tenderness and facial lacerations. So he was definitely a primary patient. So the decision was, what do we do? We've got another guy injured. There's only two people on the ground. There's no bystanders around. The decision was made that this guy, or the other guy, I should tell you, was up and ambulatory around. He didn't have the same complaints. He was quickly determined to be a patient, but more of a walking wounded green triage type of a patient, and didn't get any injury. So we did a litter extraction with the paramedic and then left the rescue tech with the other patient. So the problem with that is normally we get the patient up in the helicopter and we fly to a hospital. In this case it was in King County, would have flown to Harborview. But we've got another potential patient, and you know your exam is only as good as your exam under the conditions, right? It's a static exam and things can change. And you're leaving them with an EMT who, while they are hot shit mountaineers, they don't have a whole lot of patient contact experience. So the helicopter basically flew out, Bellevue Fire extends way out into the mountains with paramedic coverage. So just flew to them, landed, gave them the patient, and then flew back before dark to get the rescue tech and the second patient, and then turn them over to fire also. So this is just a photograph, but it's in one of those avalanche chutes on the left there. So if you ever go snowshoeing, climbing, whatever, always bring something red like a jacket or orange, because we can't see blue and green and your natural colors. It's really hard to see red even in this type of area, right? You're about a half a mile off of the slope of the mountain and trying to find out where a patient is. There's the crew chief getting ready to do something. This is taken from, we've got a camera. This is down in the hoist. It's actually a video camera. So this is hoisting the patient up. You can't really see which one of those specks there is the other patient and the rescue tech. The rescue tech's in prison orange. Can't see. Now, this is not the greatest resolution camera, but still, I tell you, it's become really difficult to see patients. So there's the flight medic down in the bottom there, swinging the patient around head first, and then we pull them in while the crew chief gives us slack. So you can see him pulling them in. And then this is the return, bringing up the second patient, and then kind of in the middle of the picture there is where the rescue tech is, holding the tagline on him. Transferred ALS ground to Harborview Medical Center. The injuries was an unstable C3 extension injury. Okay, so extension back this way, with incomplete spinal cord injury. Got better. Has potential to get worse, because what happens to soft tissue when it's wounded? It swells, right? So it swells in a spinal canal, and that can cause neurodeficit down the road. He ended up having an anterior cervical disc fusion at C3, C4, had a G-tube placed because of the swelling, wasn't able to eat or drink for a while. Also ended up having a right ankle fracture dislocation at the tibia-talar junction there. That was missed on the exam, but we were trying to get the patient out, turned over to fire, go back and get the other people before dark, so I was okay with that. He had a left, at least one rib fracture with a small pneumothorax, and he was at altitude, so that was accounting for his respiratory distress. The challenges here were resources, possible multiple criticals, turned out to not be that way, which is good, but that could have been really hairy otherwise. In fact, we could even construct a scenario in our head where we might have to send the rescue tech up with a sick patient, because it's going to be a quicker flight to turn them over to fire, leave the paramedic with the other sick patient because that person's going to be on their own for a while. Manpower, we ended up being able to use patient number 2 to assist, which was good, and fire to allow for us to return and get the people before they got stuck by dark. So the other factors was basically cold, so both the patient and the rescuers ended up getting a little bit chilled here, but no significant hypothermia. And then you always got to think at the bottom of an avalanche chute that you could have more stuff fall down on you. So addressing the challenges, what do we do with the HRT? We pick our personnel. So we want the best mountain rescue that we can have. They don't have to live around here. They just have to be, or around there. They just have to be within 30 minutes when they're on call. We want experienced medics. So you don't send out a baby medic on a case like that, on any of those cases, right? They haven't been medics long enough, and they don't see, as even in Everett Fire or Seattle Fire, they don't see as many patients in a shift as I do, and I would hate to be out there by myself, okay? So for me, a baby medic is anyone less than 5 years on the job, just like you will be baby doctors out of residency for 5 years. Training, so we have to do rotational HRT training, so that's helicopter type stuff, the hoisting, all helicopter safety, that type of stuff, communications, etc. and then additional medical training. So it's for me, actually, the challenge is with my EMTs, which I'm trying to address to get them into the emergency department so they can get some hands-on with patients. But with the paramedics, I expanded it. When I was MPD, I expanded their scope of practice. In Snohomish County, we have a protocol book that defines their scope of practice. And so we added stuff into that scope of practice, like the wound care, fracture reduction, dislocation reduction, that generally they're not allowed to do unless there's imminent loss of neurovascular loss of the foot or arm or whatever. And then antibiotic therapy. No paramedics give antibiotics in this state except for in this. I think this is the only case in the state where they give antibiotics, and all I have is Ancef on there. Normally, as an EMS medical director, I don't play the what-if game. Some paramedics, especially the ones that like things black and white, what do I do with this or this? Like, when is a patient too intoxicated to refuse treatment? Like, I'm sorry, there's no line for that. It's a gray, fuzzy border at best. So I don't play the what-if game and run review very often. But in the HRT, particularly with the paramedics, increasingly, we would draw in the rescue techs in it. We would do a lot of what-if thinking. And these guys do what-if thinking all the time. I had one of them who was one of the younger medics that we've ever had who, after 2 or 3 years, came and said, you know what, I was just thinking, holy shit, what if I'm with a really sick patient, like needs to be intubated or something like that? I don't have any backup. I've got one EMT that may be tying me into the mountain, and 95% of their brain is on technical safety, and only 5% is available to me for medical backup. So it takes a mature clinician to actually be a flight medic, so I don't let just anyone do it. Technical training, so we train, this is an actual mission, but this is another litter.
We got him in sight.
The index town wall, big climbing spot. Right over here is where our subjects are. Barely see with our low resolution camera, but that little flash of orange is a prison orange. So this is a difficult hoist because we have to be above the cliff. We can't be near the trees, obviously. You're going to clip it with your rotor blade, and then you have 4 deaths. So luckily, we have a really long hoist line. So this is one of our longest hoists that we've done. I don't remember how many feet it was. You guys, Miles, you remember? 240? 210? Okay. So that's pulling the litter up there, and then I don't remember if we took the rescue tech out or it's not a very hard climb down. So, all right. So this is just basically this is an actual case also of trying to get a patient. And you can see how it's different. This is this actual case. So we had this is an Everett Mountain Rescue ground pounder that up-climbed the wall to help out the rescue tech, who also up-climbed. They didn't hoist into it because it was about 75 feet off the ground, so just put him on the ground, and then he climbed up to the patient, which was remarkably hard in big climbing boots and not those little sneakers. But this was a big guy. He's like 6'4", 6'5", 250 pounds, trying to get him in this, and uncooperative and ungrateful, and then trying to get him in this litter on a small space there was quite kind of challenging. So this is the rescue Strop. So in the background you can see the Bauman bag and the litter, and that thing is the Strop. I'm going to put it on the flight medic. It goes underneath the arms there, clipped in the front, and then the all-important crotch line is going to be attached so they don't slip out. This is my least favorite way to get someone out because of that thoracic compression that happens as soon as it becomes load-bearing. And it's like, I don't know, chief pilot really likes it for whatever reason, but it is easy to do. And it's quicker to put on than the screamer suit is. The challenge then is because they both come up, so the challenge is then getting both of them in. You got the flight medic pulling them in the background there. It's a little bit confusing because the subject had a helicopter helmet on, but all right. So we've got a rescue Strop on a mission. So that's the rescue tech ready to go down. Got his GoPro on his helmet, so you're seeing him actually insert. So this is crappy. I mean, this is actually a cliff. The funny thing is, look at that guy. What the hell is he doing on a cliff? The things some people do are just entertaining. They just look and say, I'm just going to rock climb up there a little bit, and then they get stuck because it's scary. How far off of the slope was he? You remember? So that's what happens when you don't look down ever when you're climbing up. So this is a case where getting the screamer suit on him would have been problematic because you'd have to move him away from his death grip on, and you don't want to because he's a big guy. You could lose control of him, and boom, there he would go. I imagine it was a little bit of a challenge to get him to let go with his left hand of the rock there. And you can see that the strop is a little bit, twisted on the guy, but it doesn't matter. And then just about this point, he's like, wait a minute, I want my water bottle. He really said that too. But it got him off, and I don't think he was injured at all, so it worked out great. It wasn't a very long hoist, so he wasn't, under that compression very long. Live medic's up there they'll pull him up a little bit, and he'll pull him in. It took longer because this is one of my weaker rescue techs, but we put him on a PT program, and he got stronger. So this is a short haul. So that's what I alluded to earlier. So everybody's on the ground. Medic, patient, bystanders, search and rescue people are all on the ground. Helicopter comes back in with this really long rope that's already attached and hanging, and then just kind of lowers it. And then it gets attached to the harness straps on the bowman bag. And then with a prusik from the harness, the paramedic or the rescue tech, or even both, because it can take a lot of weight, are attached to the patient. So it's actually kind of a fun way to transport, except for you're sitting in a harness for a long time. After a while, that can be uncomfortable. And then you've got to basically land them in an open field, unhook them, and the helicopter goes and lands and takes the rope off, and then you can put them in a litter and fly them out. And another type of short haul we can do is with this thing called an air tep, which looks like an inverted umbrella. Whoops. And can hold, I think, 8 people, 8 fully equipped firefighters. We've used this with Seattle Fire to rescue them off rescuing them off the top of the skyscrapers in Seattle. Like if they get trapped by a fire further down, they go to the roof, and then they've got a way to get taken off. So you can see it's kind of a nice big thing there. You can hook in. It seems kind of scary, but it's actually quite safe. So the basic protocols for Snohomish County. Advanced protocols I talked about. Every year I do a refresher, talk about wound care, antibiotics, bandaging, reduction of basic things. For instance, shoulder reductions, which paramedics don't do in the field. They're not supposed to do in the field. But if you're in that bowman bag, which when the harness takes load, it squeezes you up like that, and so anterior shoulder dislocation, where it's out like that hurts. So they have my leave to try that.
Rescuers in front of me, and I'm going to hand him his ice axe. He's attached to it. He has his ice axe power check. Power's good. All right, moving the orca. Orca is clear. Putting in the lower.
So they just took the orca strap off him. He's now attached to the helicopter only by that cable. Paramedic had already gone in, and then the last thing that comes down, that's the rescue bag that's got the litter, some stuff to keep him warm and things like that. Otherwise, all the medical equipment goes down generally in the back of the paramedic, and a little red bag for BLS stuff that the EMT takes down.
Conditions, very steep slope, very slick. I'll keep you updated. We're switching back.
So that was the
All right, medic has the hook.
rescue tech giving an update on what's going on. The rescue tech is a ground control person. The paramedic is attending to the patient.
All right. Getting the race signal. Ready to take the load. Taking the load. I have the load. Power check. Subject is clear. I have the load. Power check. Power's good. Okay, we're going to slide left. Real slow and easy for Randy. Or left.
As you can see,
Yes, please.
rescue tech is directly nearly underneath the Bauman bag, the litter, so what happens? It starts to spin. You have to have a degree of angle for the tag line. You don't want your patient vomiting while they're trapped like this.
Gonna bring them up past the skid. They are here in front of me, bringing the subject around to the medic. There you go. Focus attached, ready for slack. Okay, ready for slack. Slack, slacking, 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 pull. Slacking, slacking.
You'll notice the crew chief is very chatty. That's to keep the pilot abreast of everything that's happening, so they know exactly what's happening.
We realize it's getting a little after 7, so we don't want to keep anybody too long if they have to take off. So maybe we can pause for a second if anybody has any questions for Ron. And I know he has some more videos and stories to share, and people can stick around additionally after that, but just want a chance for any questions.
Go on.
If not, we can just keep going.
Yeah.
What like financial responsibility do any of the people that you guys take out have?
Zero. A lot of the volunteers, and especially the traditional, most search and rescue organizations are built around a core of people in their 30s, 40s, and 50s. And then the people that are 20 years old come and go. But the ones that have been with it for a long time are, in our organization, are very adamant that they don't want any kind of charge. There are models out there in the United States and in Europe where they get a bill for a rescue, just like they would get a bill for a paramedic unit that evaluates, treats, and transports them. So, but currently we don't send them any bill. We used to send miles to them afterwards to beg for money. And they're pretty good about giving a little bit, but you know, it doesn't really support it. So the main support for this financially comes from fundraising donations from Search and Rescue / Everett Mountain Rescue and Snohomish County itself covering the helicopter, and then District 26, Fire District 26 covering the nominal sum for the medications and et cetera. But I try not to get District 26 to put in too much money because that's one small group of taxpayers in Snohomish County that are supplying something that's used in like a 10-county area. So that's, you know, there's little model problems with that, but it does take time to mature a program like this. So when the Oso mudslide happened, 2 EMTs were on the helicopter spinning up for a training flight and flew out there and did the bulk of the rescues of the people that survived, along with the Navy search and rescue from Whidbey that came out and helped. They had some corpsmen on there and packaged some patients up and took them also. At various levels of injury, some people were hurt quite badly. We're not going to show, obviously, those pictures. And then some of these were just basically rescues. But you can see the kind of the devastation. This is a horrible, horrible, this makes some of these cliffside rescues look okay, because you would walk in this mud and you could sink up to your armpits in it. And all the local fire department and the neighbors and stuff were all out flailing around in this mud helping to get these people out and had to be rescued sometimes themselves also. Generally, we tried to do low hover, and sometimes we do screamer suit, and then at least 2 patients had to be litter evacuated out because they had multiple long bone fractures in addition to thorax injuries. I'm going to watch that because I don't want to see myself on TV. So this is a good one just to kind of wrap up with what happens in the North Cascades with...
Was there snow in it, do you know? He didn't mention that, Roger.
Travis, look at the weather.
Danny, what's that little
weather to your
red
left,
thing,
Travis?
that notch right there?
Yep, I think that's him. We got him in sight, I believe.
Okay,
It's red, probably 100 feet above us. Travis, look at the weather to your left.
there.
Yeah, almost right at 3 o'clock.
Yeah, weather. Continue up.
You slide right.
You're clear to slide right. Continue up. Can you see him, Bill?
No.
So right at about 2 o'clock now, 2:30.
Well, that's the crew chief talking to Bill, the pilot, who...
Got weather coming in right around us here, Bill.
I'm watching the back door on us. And he's not, if that's him, he's certainly not moving Clear up right. We got weather coming in hard on the left.
I'm going to say abort. The weather's coming in around
Abort, abort.
Abort. Take our time. Aborting. Coming down. Roger.
Oh, look at how fast that closes in. And then imagine being in the mountains, not being able to see anything because you're in fog in a helicopter. We have a policy as part of our crew CRM, crew resource management, that safety is the highest priority. And any single person can just say abort. We're done. So you heard somebody, probably the rescue tech or somebody said, the weather's closing in, abort. And done. We're done. So a person lives or dies, that's mountaineering is treacherous. That can happen, but we're not going to add five deaths to the toll. And I don't recall what mission this was on, if that was a recovery or not anyway. But and I believe that's it. So any other questions? Anyone from Alaska or Montana or Idaho?
We're checking the emails now, Whammy. We're not seeing any.
Okay. Not to my knowledge. The only other one I know of that has paramedics, the last time I checked, was Ventura County in California. And they were deputies that were then trained as paramedics. I don't think they traveled. We went down there and learned some hoist techniques from them, because we learned most of our hoisting from the Coast Guard, because no one can hoist put you on a dime 200 feet down on ships that are going like this in a rainstorm with rogue waves coming and sweeping over the helicopter like the Coast Guard can. But they don't have paramedics. Neither does the Navy. They've got corpsmen, which are kind of a quasi-EMT at best, and usually just a rescue swimmer. So Ventura County has paramedics. They don't carry quite the equipment we do, and they don't have the mountain rescue side of it. So, they do know their ropes, like a firefighter would, but they don't have the expertise of the mountain rescue technician, which is huge, huge key part of this program. The reason we started training the flight medics for this is they used to just go and pick up a paramedic from Lake Stevens Fire or someone like that and fly him in. These guys would go out in their polyester pants or bunker gear, inappropriate boots, no rescue equipment, no ice axe, no crampons, no harness. They get put down, and after we put down one woman on a mountainside and the weather started closing in or something, and she's like, I'm never doing this again. That's where the program came from. But still, paramedics aren't as, so it's the dangerousness of the missions where we go and put an ALS provider, so a paramedic or myself, on these slopes is 1,000% higher than what we used to do before this HRT actually started. So when we just snatch a paramedic. What else? Yes, sir.
So is this kind of a unique model then across the country? And if it is, have you considered reaching out to introducing it elsewhere? Or?
Well, it is known. It is a unique model. After we were in a kind of a budget crisis because of the recession, the program looked like it was going to end. The county didn't want to put out the money for it anymore. It's $150, right? They spent $820,000 a year buying drugs from people. So anyway. The county said that I have to stop that. But yes, it's a unique model. After we were fundraising, and then OSO happened, which kicked us right into the absolute spotlight, made the county commissioners support the program and then help bring in money, but also got recognized both in the aviation sphere, the rescue sphere. They had articles in some of the throwaway journals like GEMS for paramedics, but so they actually ended up getting an award down in Florida, which was the Golden something award, the Golden Fleece, I don't know, something like that. I didn't go. They never fly me to any of these things. But actually went out and trained with a squadron in Portugal not too long ago. And we've trained with the National Guard, because the National Guard was out at OSO also, like in the third day or fourth day onward. And so they still don't have the ALS capability, but at least they're better at hoisting and rescue type of stuff. So it's kind of limited by the fact that we're all volunteers. We've all got other jobs. I mean, I've got 5 jobs, so I don't have a huge amount of time to as much as I'd like to devote to this, and all of us have other jobs. So if this is all we did, if this paid me $300,000 a year, I'd do it full time. Even just usually sitting around thinking of shit that could happen, right? So, but it is what it is, and this is the United States of America, and we've got all kinds of funding models. And so Snohomish County, even though it's a county of 800,000 people, only has so much funds that they'll funnel in to save 80 people a year, especially when 50 of them are outside the county. So, but yes, it is a unique model. It is part of the Regional Aviation Rescue Unit Consortium. Thank you. So Pierce County provides fixed wing. King County provides 2 Hueys. They've started putting paramedics on them, actually. They started copying us, basically. So, and mountain rescue, but I don't know how closely they work together, but they do have a lot fancier patches and stuff than we do, stuff on their helmets and stuff. And then we provide the ALS. So if there's a disaster, whatever, we can call on the Regional Aviation Rescue Consortium for whatever we need. So it worked well with OSO. So Guardian 1 and Guardian 2, which are the King County Hueys, came up to do kind of non-critical transports, at least half of which was flying around senators and Congress people and governors and stuff like that around. And Washington State Patrol provided air restriction and that type of thing. So, but it's very unique. So it's quite fun to be involved in. Now is our quiet time of year. Most of our training missions get scrubbed because of weather. We don't fly in terrible weather just to go train. So come about May, we really start ramping up the training. We've all got to get out there, get back on the rotations. You don't want to be rusty and then forget to attach something. That could be really bad. So, and then much less our medical aspects of it. Any other questions?
So as a physician being the medical director, what was some training that you did do or wish you had done to better prepare you to be the director?
I came into the job perfectly suited for it because I was a surgery resident for 2 years, so I have the level of arrogance needed and the confidence of emergency medicine, et cetera. No, it's not difficult medicine. I learned to be a medical director for EMS, right? So not long after I got out of residency, I wanted to get into EMS. Lights and sirens are fun, and pre-hospital medicine is fun. So I started that 15 years ago. So as far as knowing the administrative aspects of it, I learned as I went. But this thing started out kind of de novo, right, from nothing. So there's not really any class to go to, course, fellowship that would really be appropriate. I've done, wilderness medicine courses, certainly. I've done, several of those. I stopped doing those because there's generally not much new and it's the same stuff over and over again. But there wasn't a lot of unique medicine. We don't have high altitude medicine problems here. Even at the very tippy top of Mount Rainier, no one's head is going to explode. No one's lungs are going to fill with fluid. So you just get nauseated or whatever. So, a lot of the aspects of expedition medicine, wilderness medicine, it's just basically kind of extrapolating what you already know. So what you learn in medical school, what you learn in residency, if you go into a residency that's kind of applicable to this, which would be pretty much general surgery or emergency medicine, you're going to have the skill set. That's part of being a physician, is being able to figure out what to do without having to go somewhere and have someone explain it to you. Right? So you learn the physiology, learn the pathophysiology, and go. So that's kind of how I got it. So a lot of it was just luck, right? So I was an EMS physician. I liked it. I planned on being MPD when I was 50, right? So 10 years. When I was 39, the guy died. Clearly, the office doesn't open up that much, so I went for it. And then within a few months, this happened to be starting up, and so I, said, I have statutory authority over you. You can't do this unless you let me play. And then I went in and I sat down with the paramedics. We would meet and we just kind of evolved it from there. We started off, we were sitting around going, well, what drugs should we carry? So there's a whole lot of what if thinking that you had to do. And then over the years, as we got experience with a patient population, we can hone down what we have, what we carry, what kind of stuff we need, what we don't need, that type of stuff. So it was basically on-the-job training, but that's kind of the best type of training, yes.
Just to follow up, did you do any fellowship in wilderness medicine, or did you do a fellowship after residency?
No. I have 5 years of residency. I did 2 years of surgery and then 5 years of residency. I was done. I'm like, I'm 35 years old or 33, something like that. I'm like, I'm done training. Okay, I don't want to do any more training. They do have EMS fellowships, and I can grandfather into it. I just have to, pay the thousands of dollars and take the test. It's very heavily kind of administration oriented. It's not this. So there is a Wilderness Medicine Society out there, which I've been a member of, generally speaking. So I forget to pay my dues a lot, but for many years. And they do have a fellowship there. But it's like being a fellow of the American College of Surgeons. It was basically, I pay you $100 and I fill out an application type thing. It's not like it's not, going to the conferences is good, and I could pick out the stuff that I thought would be useful for this type of stuff. But I don't think there's any fellowship that really would be applicable to this. All this type of training is your backcountry, your wilderness medicine type stuff. And those are basically through various courses throughout the United States and throughout the world type of stuff. Those courses would be the same curriculum whether you're going to do this type of stuff or whether you're going to do Everest Base Camp type of stuff. So, and I've done those. And I'm not really a letters chaser. Once I got the FACEP after my MD, I'm like, plenty of alphabets, and I don't really need any more. So, so I didn't really pursue that. Anyone else? All right. Thanks for coming.